at the IMS meeting last week in Athens, I had the honor and the pleasure to share a session on redirecting the therapy in multiple myeloma. And I also gave a talk on how the landscape in first relapse myeloma is evolving. Basically, to summarize that talk, I started mentioning that when we are confronted with a patient with relapsed myeloma, it's important to keep in the back of our head that decision should be based on the myeloma itself, the type of relapse. Is it an aggressive relapse? What about high-risk features, even extramedullary disease? There is, of course, the previous treatment, which drugs were given, how long, were there side effects, were these reversible? And last but not least, there is the patient and the situation, let's say, not only age, but frailty, status, comorbidities can be different compared to when the patient was newly diagnosed. So having said that, currently, the treatment at first relapse is still drug-based, usually triplets rather than doublets. Although the percentage is decreasing, there is still a subgroup of patients who are considered to be lenalidomide sensitive because they did not receive len until progression. And for those patients, len-based triplet combinations like Dara-RD or KRD are very attractive. In particular, Dara-RD given a median PFS of more than 50 months at first relapse compared to 18 months with RD alone. And another alternative could be, for instance, KRD, where the median PFS at first relapse is around 30 months. But the truth is that more and more patients are these days lenalidomide refractory. And for those patients, we need to try to find other options. And these options can be based on a proteasome inhibitor backbone, like, for instance, the combination of Dara-VD, pomalidomide VD, even selinexor VD, or knowing that carfilzomib is superior to bortezomib in relapsed myeloma for, let's say, the fitter patient that can tolerate carfilzomib, combinations like Dara-KD and Isa-KD are very effective with a median PFS around 2.5 years for those patients. And looking at the sub-analysis of those studies, len refractory patients seem to benefit to a similar extent with those combinations than non-len refractory patients. There is the option of going for a pomalidomide-based regimen, like, for instance, daratumumab PD. Here we have maybe some conflicting results. There was the Apollo study, which enrolled primarily patients in later relapse, mostly len refractory with a median PFS of 12 months. There was a smaller US phase 2 study that showed in a similar setting a PFS that was longer and approached 2 years with that combination. But so there is a lot of regimens to choose from, but the choice should be driven based on, let's say, disease, patient characteristics, and also availability and maybe also some personal experience. Things are changing because also more patients, especially elderly patients, receive daratumumab up front. So when those patients relapse, they will be frequently refractory to both lenalidomide and daratumumab. And then the options that are drug-based are very restricted. During 2023, there are two important studies have been published. Prospective randomized phase 3 studies that compare the BCMA targeting CAR T cells with the standard of care triplet regimens. The first study was the KarMMa-3 trial that compared ide-cel with drug-based combinations, and you could choose out of 5 different combos, mostly triplets. That study showed clear superiority of one single infusion of ide-cel over the drug-based treatment. significantly longer PFS, more response, more CR, more MRD negativity. So that means that the concept of frequently continuous treatment with drug-based regimens can be outcompeted in terms of efficacy by infusion of CAR T cells. I have to mention that in this trial, when you see the follow-up of the PFS, you see that both curves start to merge, come together. So there's no plateau for the patients who received ide-cel. Along the same line, there was the CARTITUDE-4 study that compared cilta-cel with either a triplet combination like PVD or Dara-VD. And this enrolled patients who were a little bit less extensively pretreated compared to the KarMMa-3 trial. But all patients in that study were Len refractory. And when the results were released at EHA and ASCO, it was quite astonishing because the median PFS with the drug-based combos is around 1 year. And after 1 year, 3 out of 4 patients who received cilta-cel are still alive and without progression. And also here, impressive overall response rates, very high rates of complete remission, and many patients achieve MRD negativity. So in other words, I think based on those two studies, we see that the treatment landscape for relapsed myeloma, especially for early relapse, could be potentially revolutionized because this drug treatment can be replaced by one single infusion of CAR T cells. But okay, that's for the time being not yet the reality because of several reasons, if not by access. And first of all, also, we need to wait for the registration. Then there is, of course, also good news with the bispecific antibodies because there have been several phase 3 studies conducted, or they are being conducted, that also compare bispecific antibody directed against BCMA or another target like GPRC5D or FC receptor homology 5 domain, and where this bispecific is compared also with triplet drug-based regimens. So we eagerly look forward to the outcome of those studies to see if they also show superiority over the more traditional approach. So I think in summary that we are in very interesting times, and the most important take-home message is that this is good news for patients. And although the currently available drug-based regimens have shown they are highly effective, we could potentially do better with these new T-cell redirecting therapies.